Welcome back to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, here with our great Wendy Simmons, and this is part 3 of our EULAR Osteoporosis RhAPP Up. We've covered some interesting information thus far, and in this final episode, we will wrap things up. So let's go ahead and dive right in. I will go over Abstract 1, POS0848, Longitudinal Impact of Menopause on Bone Health and Osteoporosis in Women with Spondyloarthritis. Results from the DESER cohort. The overview of this study: this was a prospective longitudinal study evaluating the long-term impact of menopause on bone mineral density, osteoporosis risk, and fracture outcomes in women with early spondyloarthritis from the DESER cohort over 10 years of follow-up. The background or purpose of this study was that osteoporosis is a recognized complication of spondyloarthritis and may occur early in the disease course. Menopause is an additional major risk factor for bone loss and fractures, potentially compounding skeletal risk in women with SPA. This study aimed to better characterize how menopause influences bone health trajectories over time in women with early spondyloarthritis. Investigators analyzed data from the DESER cohort, a French multi-center observational study following patients with early spondyloarthritis for up to 10 years. Bone mineral density was measured longitudinally at the L-spine, total hip, and femoral neck. Linear mixed effect models were used to assess annual BMD changes and evaluate associations between menopause, medications, body mass index, and other clinical variables on bone loss trajectories. The results were that at 10 years, approximately 1/4 of women in the cohort were menopausal. Significant bone mineral density decline occurred at all skeletal sites, with the greatest loss observed at the femoral neck. Menopause was independently associated with accelerated bone loss across all measured sites, contributing an additional decline of roughly 0.4% per year. Higher body mass index demonstrated a protective effect against bone loss. Importantly, anti-TNF therapy and NSAID use were associated with slower rates of bone mineral dense decline, while corticosteroid use accelerated bone loss. The protective effects of anti-TNF therapy was particularly notable at the femoral neck and total hip. Despite ongoing bone loss, fracture prevalence remained relatively low during the study period. The conclusions were that women with spondyloarthritis experience progressive bone mineral density loss over time, with menopause significantly accelerating this process. Anti-TNF therapy and NSAID use appeared to mitigate bone loss, while glucocorticoid worsened skeletal decline. These findings emphasize the importance of bone health monitoring and individualized osteoporosis risk management in women with spondyloarthritis, particularly during and after menopause. So, very interesting study. Wendy, I'm very excited and interested to hear what your thoughts are. None of this is shocking to me, but I'm interested to see what you say.
Oh my gosh, I am busting at the seams completely. Love this one. Love this abstract. Fabulous. And it's a complete, appropriate teaching tool, especially for us in rheumatology as well. There's no doubt menopause is hateful to bone health for sure in these women. And this is the reason I'm passionate about this as well, is it combines two things I love. Patients with spondyloarthritis and osteoporosis. And it's tough. It's a tough one, as you know. First of all, with getting the diagnosis for the spondyloarthritis, we know through our education, the inflammation that occurs at those enthesial sites along the spine, and that does lead to osteoporosis. thinning, of the bone there as well as other sites. Then, as shown here, layering on menopause, that really accelerates the risk alone. I do have patients, and it can be difficult when you're doing bone densities because the spine certainly could be potentially elevated a little bit in bone density if you're picking up, any type of, extra bone, where they're being measured, the technician, if you're having changes with spondyloarthritis or syndesmophytes, if you've got a radiographic patient. But also the whole process of remodeling is changed in those patients with spondyloarthritis with that inflammatory process. So first of all, we know the disease state does contribute to osteoporosis. And then we're going to be having menopause. These patients, you have at a younger age population. Um, you're not really going to be treating premenopausal patients specifically with agents for osteoporosis. But I think there's no doubt if that patient uh, has spondyloarthritis, find out where they are with regard to menopause. You know, are they going to have surgical menopause? That's something to pay attention to for evaluation. Are they going through any type of an early menopause as well? I've seen patients with spondyloarthritis present in fractures. Patients been sent to me. They've been thought to have degenerative changes of the spine and literally have had surgery. I have one patient in particular had surgery, had rods in the spine, and I acquired the imaging studies, and there were syndesmophytes. I mean, that's almost given to me on a platter. However, where the patient was, where they had the spine evaluation and the surgery for the degenerative changes, it was not picked up that that patient had the syndesmophytes was, rheumatologic process. So that patient was actually picked up by me presenting with fractures. I think this does show the importance. We don't want to be at that point. We want to pick up our own patients as well. I love this because there was a length to this analysis, 10 years as well. They were able to follow bone mineral density changes. They also, in this abstract, it was nice, they did take into other considerations, body mass index, other clinical variables, so they could follow these patients. I'm sure a lot of education for these patients. And then to comment on the anti-TNF therapy and the NSAIDs, we know those are great treatments in these patients with spondyloarthritis. And perhaps in this population, in this abstract study, the disease was controlled. There's not specific information. I'd love to see a little bit more information there. But I do feel, first and foremost, I'm sure the disease state was controlled as well. So great combination, slowing or stopping any bone loss. Then, you are dealing with that. Steroids, I don't feel that we use a whole lot in this patient population. Not sure, certainly in your patients as well. I feel that once you understand this concept, then it is easier to follow. But boy, when you order those bone densities, I had one this week, was actually a male though that has fractured because it has happened in them as well. And a lot of times it's the disease process. Sometimes you get these bone densities back and they're almost near normal, but the kyphosis is progressing in some of these patients. So trabecular bone scores are helpful. Certainly imaging helps us as well. Does that help a little?
It does. Yeah, you always teach me so much about osteoporosis, so I really value that. And, again, I think this just highlights the importance that we need to really be seeing our patient as a whole and really kind of think about, where they are in their stages of life, particularly our women. And don't forget to order the bone density in a menopausal, woman. And to your point, think about, surgical menopause as well. And so, again, I think this study was not there wasn't anything, super, surprising to me, but again, I think it just highlights the importance that we continue to monitor our patients closely.
Absolutely, I agree. Nothing super surprising, just you know, a lot more to certainly continue to pay attention to as well in these patients. And again, it takes time. We're really busy in clinic with our disease state patients. Then you have another comorbidity complication, osteoporosis, and certainly use the FRAC score as well. That's one thing I do say because even I have a lot of surprises there. I think it does help with documentation if you want to jump in, what therapy am I going to start in this patient? Again, I love the sequencing. I know this isn't about therapy, but it's a great point. All right. We're going to be wrapping up, finalizing with the last abstract as well. And another exciting one that I think is a great way for us to complete this series. Abstract 2, OPO172, romosozumab versus denosumab in glucocorticoid-induced osteoporosis, an extended observation of a randomized controlled trial at 48 months. Overview of study. This extended randomized controlled trial evaluated long-term outcomes of sequential romosozumab followed by denosumab compared with denosumab alone in patients with glucocorticoid-induced steroid osteoporosis who were at high fracture risk. The analysis examined both the bone mineral density and trabecular bone score outcomes through 48 months. Background and purpose: patients receiving long-term glucocorticoid therapy are at substantial risk for osteoporosis and fractures. While denosumab is an established anti-resort to therapy, romosozumab offers anabolic bone building effects that may provide greater skeletal benefit when used earlier in treatment. This study aimed to determine whether an initial course of romosozumab followed by denosumab provides superior long-term bone outcomes compared with denosumab alone in glucocorticoid-induced osteoporosis. Methods: adults receiving chronic oral glucocorticoid therapy with high fracture risk were randomized to receive either monthly romosozumab or denosumab for 12 months. After initial treatment phase, the groups received denosumab every 6 months for an additional 3 years. Investigators addressed changes in bone mineral density at the spine, hip, and femoral neck, along with trabecular bone scores through 48 months of follow-up. Results: at 48 months, patients receiving sequential romosozumab followed by denosumab demonstrated significantly greater improvements in spine and hip bone mineral density compared with denosumab alone. In the romosozumab-denosumab group, spine bone mineral density increased by more than 11% and hip bone mineral density by more than 6% from baseline. Improvements were also observed at the femoral neck. Trabecular bone score improvement significantly in the denosumab group, but not in the denosumab alone group, suggesting enhanced bone microarchitecture with anabolic-first therapy. Fractures and cardiovascular events occurred in both groups at relatively similar rates over the 48-month follow-up period. Author's conclusion: sequential therapy with Romo followed by Deno was superior to denosumab alone for improving spine and hip bone mineral density and trabecular bone score in patients with glucocorticoid-induced osteoporosis. These findings support the potential value of anabolic-first treatment strategies in patients at very high fracture risk receiving long-term glucocorticoid therapy. Amanda, impact on the patients. Does this surprise you? It's consistent with what you see.
It does not surprise me, and I think it just makes me feel better about what I'm doing and what you have taught me about
Yeah.
osteoporosis and how to treat these patients. And so, again, I will say that this is often a strategy that I will use for my patients with osteoporosis, particularly those that are at a very high risk for fracture or who have fractured. And so it's kind of nice to have a study that, reaffirms what I'm doing.
Absolutely. And again, well done study, controlled study, nice length of time, analysis with bone mineral density, also looking at that trabecular bone score outcome. Um, all through this, definitely shows us, again, what we've been talking about, just sequencing that therapy if you're able to do that. You've got a 12-month approved therapy followed by a therapy that potentially doesn't have a definite stopping point in patients as well. Going back to, you want to build that house before you remodel that house. You want to get that solid skeletal structure. Again, we can't look into that matrix. We want to be able to build and get that strong matrix before we start trying to remodel it as well. I also I like, again, that we're able to get a little piece of data in there that patients did not have fractures, cardiovascular events occurring in any type of an alarming rate. We certainly didn't see the specific any numbers there, but nothing out of the ordinary compared to other studies, it looks like, out of this as well. What an absolute wonderful abstract to end the series, I think, as well, because this one certainly is relative to what we are all doing in our rheumatology osteoporosis clinics. Whatever your setting is where you're practicing with your patients, information is really well presented here to understand. We've learned a lot today. Treat to target, sequencing therapies, and following those patients' bone densities. Thank you.
Absolutely. Well, that brings us to an end of our EULAR Osteoporosis RhAPP Up Series. A huge thank you to Wendy for joining us and sharing her expertise across the series. We hope this series helped break down the most important updates on osteoporosis from the 2026 EULAR Congress and gave you some valuable takeaways for your clinical practice. If you enjoyed this episode, be sure to follow RhAPPcast so you never miss an update. And don't keep it to yourself. Please share all of RhAPP's digital education from the content room with your friends and colleagues. You can also follow RhAPP on social media for more education, updates, and community discussions. Find us on LinkedIn under Rheumatology Advanced Practice Providers, Instagram or X under @RhAPP, and on Facebook as well. Thank you again for tuning in, and we will see you next time on RhAPPcast.